Hello, this is EKG Recognition and Understanding for Nursing Students. This lecture is brought to you by Professor Lewis Kaplan of Simmons College in accordance as well with Justin Hooks, a nursing student and critical care paramedic and ACLS instructor. Within this lecture, we're going to identify electrical pathology or physiology of the heart. We're going to learn how to correctly place leads for telemetry, including 3 leads and 5 leads. We're also going to learn about 12-lead EKGs. Most importantly, we're going to understand and recognize how to count the rate for an EKG strip, identify the portions of an EKG in relationship to the cardiac cycle, and recognize most common ECG abnormalities. So action potential in the heart is the creation and transport of electrical activity throughout the heart muscle. Within the heart muscle, we have myocardial cells that are usually pacemaker sites, which we're going to talk about. And we're going to talk about the absolute refractory period and the relative refractory period in relationship to EKG tracings. So this is your common EKG tracing that you will see here, the P wave, the Q, and the R, and the S, as well as the T. And so the P wave, to think to yourself, is going to represent the sinus atrial node, which is the first pacemaker of the heart. And that is an indicator of a positive deflection of the P wave right here. So if a rhythm has a P wave, it will be indicative of a sinus rhythm, as you probably heard that before. The next site that we have is the AV node, and then after that the Purkinje fibers. As the electrical impulse travels from here to here down to here, you see deflections, positive deflections on the EKG tracings. Just indicate the closure and of the action potential within there. So we're going to start off with talking about the electrical pathways of the heart. So the best way to describe it is, if you're familiar with baseball. In baseball, you have 3 strikes until you're out. And so within the heart, you actually get 3 strikes until you're out as well. And so the first pacemaker of the heart, located in the very uppermost portion, would be your sinus atrial node, considered the SA node. This pacemaker is your number 1 pacemaker of the heart, and that will stimulate a electrical impulse for the heart to contract and go down the pathway between 60 and 100 beats per minute. The next one after that, say if there's any disease process or this SA node is faulty. Good example that I like to use is if there is a myocardial infarction within the top portion of the atria and this SA node gets burnt out, rest assured there is a backup. And so you had 1 strike. Your second strike is going to be the AV node, atrial ventricular, because it's right within that area of the atrial ventricular border. This will stimulate an electrical impulse between 40 and 60 beats per minute. And say, for example, your heart attack that you had that was right up here, that now has gone through and extended to the portion of the atria and is now moving down towards the ventricle, and that other site is burnt out or any other disease process becomes faulty, you have your Purkinje fibers, and they are your third strike and final strike, and they will stimulate an electrical impulse or a beat of the heart between 15 to 40 beats per minute. Some textbooks will say 20 to 40. So the SA node is the number 1 node. It is the intrinsic rate of the heart. It will beat between 60 and 100 beats per minute. When we talk about tachycardia and bradycardia, it's in a relationship to the baseline rhythm. So a heart rate that we're going to talk about is sinus tachycardia. We're also going to talk about sinus bradycardia. So it's important that you know the normal limits of each of the nodes, because, for example, a sinus rhythm, if it was sinus tachycardia, that is by clinical definition a sinus rhythm that is greater than 100 beats per minute. On the opposite side, if a rhythm is sinus bradycardia, by definition in clinical presentation, that will have a P wave and it will have a heart rate or that you count less than 60 beats per minute. So you can have tachycardias, you can have atrial tachycardia, for example. So atrial tachycardia will be, the normal is 40 to 60 beats per minute. So if um, a rhythm that is an atrial rhythm is greater than 60 beats per minute, say 70 for example, that would be considered by definition tachycardia. So it's really important that you understand and recognize what is the normal beats per minute in a rhythm. The AV node is your second strike, and so that will beat between 40 and 60 beats per minute. Rhythms that are AV or that come from or atrial of nature that we consider are usually EKGs that have an absent P wave or an inverted P wave, so a flipped P wave. And lastly, your third strike, and third strike only, is your Purkinje fibers, which you have the bundle branch blocks, which we are going to talk about the bundle branch block. I'm just going to highlight what it is. But you have your Purkinje fibers right here that will stimulate an electrical impulse between either 15 or 20 to 40 beats per minute. So when it comes to monitoring the heart, there are two different things in nursing that we do. The first one is a 12 lead. 12 lead is a one-time snapshot of the heart's electrical activity. A 12 lead has 12 views but only 10 electrodes. It's kind of confusing, but it has more views. So we're going to talk more about that when we get into 12 leads, but it will give you a clear definition. How a 12 lead works is it will do, and it will make more sense when I show you an example, it would take 3 seconds, 3 seconds, 3 seconds, and 3 seconds at a time. So from start to finish, when the technician or the nurse takes a 12 lead, they will push start. It will go for 12 seconds and take a snapshot and different views of the heart over 12 seconds. And when it comes to telemetry, telemetry is continuous. However, it does not show a complete 360-degree view of the heart. The good thing that we do have with telemetry is most of the times they do have a data that is stored, so you can go look back in time, especially if someone is having what we call runs of ventricular tachycardia. That is something that we can go back on a continuous telemetry that the patient wears, and we can see. We can also print out, and telemetry is something that is occurring continuously. And so this is what, if you want to see how your patient's doing, if they're not saying they're not feeling well, that they feel very faint, you can look at the telemetry monitor and actually look at their heart rate and see the tracing. So with the 12 lead EKG and the EKGs, with 12 lead EKG lead placement, when we talk about lead placements, you will hear precordial leads and you will hear chest leads. Same thing used interchangeably, or you also hear limb leads. So limb leads, as they are defined, go on the limbs. A lot of people try to put limb leads on the chest. However, that is not where they are supposed to be. The importance of when we talk about lead placement is a big deal, because where you place your leads can give a different deflection. And so typically, just like any electrical activity, when we place leads on the chest or stickers, we are going from a negative to a positive deflection. So typically we like to look at lead 2, because lead 2 goes from the right arm all the way down to the left leg, and so that is directly involved right in the center of the chest. Lead 3 is more of a superior view. Lead 1 is from the right arm all the way to the left arm, so it's kind of a lateral view that we have. AVR, AVL, and AVSF, what these leads are, what the A stands for, is augmented vector right, augmented vector left, and augmented vector front. And so you will see that they have AVF leads. It would make more sense when we talk about 12 leads. And then when it comes to the V leads, so the precordial leads, these are going to be leads that are placed on the anterior portion of the chest to try to give different views of the heart. So 12 lead, like I said, we will talk more about this in the later lecture. What we are looking for, and this is 3 seconds of time, 3 seconds of time here, 3 seconds of time here, 3 seconds of time here. So this whole picture is not taken all at one snapshot. It occurs over time at 3 seconds, 3 seconds, 3 seconds, and 3 seconds. The result is what we are looking for. We'll get more into detail, but we're looking at for classical findings of ST elevation and ST depression. So telemetry lead placement, like I said earlier, you have limb leads, and limb leads are just that. They are specifically indicated for the right arm, which is your white lead, your left arm, which is your black lead, and then your left lower, which is your red lead, and your right lower is your green lead. People like to use the thing over smoke, over fire, and so they will use something like that. For me, that never worked out, so I just know that white, black, red, green. If you're very fortunate, most of the time they're listed RA, LA, LL, RL. So this is your 4 lead that we have. Other leads, a 6 lead or a 5 lead, is going to be your right arm, left lower, right lower. They do a modified chest lead, which we call V1 position, which is the 4th intercostal space. And sometimes we may monitor for V6, which is another lead that will place right in towards the center of the nipple, posteriorly. So when we're looking at a telemetry tracing, what we're looking at is a 6-second strip. A 6-second strip is a good snapshot and a good baseline to start. It gives us a lot of information. So typically when you do print out any EKG, you're going to see some hash marks noticed at the very top right here. And so what these hash marks are, they are indicating to you between this distance and this distance that this is a 3-second interval. So when you're looking at an EKG strip, you actually want to have 2, 3 hash marks. So you want to have 3 seconds there, 3 seconds before. And so when we're looking at an EKG, we're going to identify different things that we're going to go over in the next couple slides that will help us take a view of what's going on in the heart. To identify the rate, what we're going to do is count what we call the R waves. And so you're just going to count and you're going to multiply it, since it's a 6-second strip and you want to do it per minute. So it's going to be counting the number of R waves and timesing it by 10. So you're going to have 1, 2, 3, 4, 5, 6, 7, 8. So this rhythm right here is 80. Hard to see. So when we're looking at an EKG, there's a couple steps that we want to go through. First thing that we want to do is count the rate. We want to see if there a P wave for every QRS complex. As I said before, P waves are indicative and a classic that tells you that is originating from the sinus node or the SA node, and so you want to see that there's P waves there. The next thing that you're going to do is look and count the rate. We're going to see how fast it is. We want to look at the rhythm, whether it's regular or irregular. So that involves us actually mapping it out. So we're actually going to have to do some tracings to do that. We're going to see if everything returns to baseline. If there's the QRS complex, is the QRS complex within normal limits? Is it wide or is it big? That's kind of important too. And how are our intervals? Is our PR interval within normal limits? It should be between 0.12 to 0.20. Is our QRS complex between 0.08 and 0.12? If it's a deviation of any of those, then we get into different types of rhythms that we name or diagnose. There's other ways that you can do. You can count a 300 using the 300 rule, what you're basically doing is counting how many big boxes are in between each R wave. So it'd be 300. If it's one box, after that it's 150. If it's after that, it's 100, 70, I think 65. So it goes in that way. The 300 rate, just like even doing the 6 times, counting the boxes of 6-second strip, it's not the most accurate, but it's just a typical guess to get us there. So the first thing that we want to do is we want to look and count our rate, see what our rate is. Our rate is going to be a clear indicator of telling us whether it's too fast, too slow, or just about right. So when it comes down to evaluating the rhythm, which is the next spot, the best thing that you can do, especially if you're beginning to this, is literally map everything out. You can print out another strip right here, and what you want to do is actually mark on the paper from, typically what I do is I use the border of the paper. If I torn off a piece of EKG tracing, I'll do that and I'll measure from here to here, and I'll look at that distance, and then what I do is I'll take that and I will go and measure the next distances to see if they pretty much match up. So when we talk about whether a rhythm is regular versus irregular, means whether the distance between this R wave and that R wave is consistent amongst the rhythm, or does it vary? And so if you have any variances of it, then we're going to talk about rhythms such as atrial fibrillation, and we're going to talk about rhythms such as a premature atrial contraction as well as a premature ventricular contraction, which you're going to see some irregularities between the R waves. The next thing we're going to do too is we're going to look and see, is there P waves there? Taking a piece of paper, going through, looking at it, marking your R waves, seeing the distance between. Like I said, it's not a good practice just to go and say, eyeball this and say, oh yeah, that looks about right, that looks about right, that looks about right. Yeah, it's not a good practice because you can be fooled by how it may be subtle, but there will be some differences. And this person couldn't have what we call a complete heart block, and you can completely miss it. So we're going to look at P waves, and we're going to look at something what we call a PR interval. So keep in mind, for demonstration purposes, I will give the warning. This is a blown up image, and so our intervals are going to be off on this one. So what we're looking for is P waves. We're looking, the P wave that's present is significant, saying that it is firing from the sinoatrial node. It would go down, so your P wave is your first deflection here. Now, something that a lot of people get confused with is the QRS complex. So your Q wave is going to be your first negative deflection. It may not be as pronounced as this. Sometimes it may not even be present, but your Q wave is going to be your first negative deflection. Your R wave is going to be this positive deflection, and your S wave is going to be this deflection. And then you're going to return to baseline with some ventricular repolarization. So what the P wave is indicative of is the firing of the sinoatrial node. It's saying that there is a signal pathway that is going through the atria. So if you take this P wave right here, if you were to draw an A, if you can kind of see that, draw an A, that is originating from the atria. Now the next thing that we have is the QRS complex, the depolarization of that. If you look at this, this is an upside down V. So this is your ventricular depolarization. So upside down V, ventricular depolarization. And then you have ventricular repolarization. And a lot of people will ask, where is the atrial repolarization? Because we have atrial depolarization, ventricular depolarization, then we have ventricular repolarization, but where are the atrial repolarized? And the answer is that this atrial repolarization occurs during this QRS complex. So you're not going to see any signal that is going to be indicative of that. So a normal PR interval, and we're measuring from the start of the P wave all the way to the end of the P wave. Like I said, this is not a good picture to do that. It should be between 3 boxes and 4 boxes. Just for review, and if you do not know this already, each one of these small boxes is 0.04 seconds. So each of these little boxes is 0.04 seconds. So one big box of an EKG tracing, okay, one big box right here is 0.20. So these small boxes right here is 0.04. So we're looking at the PR interval. I'm going to start here. I'm going to end here because my Q wave is here, my R wave is here, my S wave is here, and T wave is here. So we're going to start at the beginning of the upslope and we're going to stop right where it starts to go down. So that is our PR interval. So on this person, I'm going to count 1, 2, 3, 4. It's right about 0.16 or 0.12. It's really hard since these are not matching up in the right as I want to be, but this is going to be a normal PR interval. So you can see that there. QRS complex is going to be your ventricular depolarization. As I said, it should be between 0.4 to 0.12. Typically, it's around 0.08. Depends on how fast the rhythm is. If a rhythm is fast, or we have a tachycardic rhythm, you will see QRS complexes at 0.04. If it's within normal limits, you usually see a QRS complex of 0.08. So if you have a sinus rhythm between 60 and 100 beats per minute, you'll see a QRS complex of 0.08. QT interval is very important because there is a distance between this Q wave, the downward deflection, and to the end of the T wave. A QT interval is a combination of the ventricular depolarization and repolarization. And what we need to do as far as monitoring that is there are medications that we can give that do prolong that, even in females with antibiotics as well, can cause QT interval prolongation. And so the problem that we worry about with QT interval prolongation is that this amount of spacing is getting too much for us. The ventricles are getting too much, and so we can have aberrant conduction such as ventricular tachycardia, really bad rhythms that can come out of it. The next thing that we're going to do after that is evaluate, go back and look at your P waves, make sure after we did all of our measurements, we're going to make sure the P wave for every QRS, QRS complex, T waves, so forth. We're going to look at the ST complex, ST segment, see if it's elevated, if it's at normal limits. That, if you're looking at a telemetry strip where you're only seeing one lead, if there's ST elevation, that's not a clear definition, but just so that you know, ST segment elevation is associated with myocardial infarction, so that's why we do worry about it. T waves can be elevated. If a T wave is high, this is something condition called hyperkalemia. If the T waves are low, this is associated with hypokalemia. So we can see electrolyte deficiencies related to the different waves as well. So clinically, we're going to look at the ST waves. We're going to see how they are. I'm going to talk more in detail as we get through. Like I said, T waves can be indicative of hyperkalemia and hypokalemia. U waves can also be a sign of hypokalemia, but it also can be an indicative of hypothermia as well that we look for. So the isoelectric line is different. So what isoelectric line is, you're going to be your baseline. So we measure all of our waves from the isoelectric line. So if you were to take these waves and draw a line all the way through the bottom, just where they would basically touch, that's going to be our isoelectric line. So it's going to be right at the P wave. We're going to draw this right here. draw this right here. What our isoelectric line is what we measure from baseline. So we can measure ST elevation from that isoelectric line. We can have P waves that are elevated, which is normal, or we can have P waves that are inverted below the isoelectric line, which is going to tell us something else is going on. Same thing in the case of T waves, where they are elevated, or they could actually be inverted, which will tell us hypokalemia. So now we get into the good part. We're going to talk about the first rhythm, which is the sinus rhythm. So a sinus rhythm, what we're looking for, we're going to do a couple things. So we want to identify a rhythm first. We want to see if this rhythm, what the rate is. So the rate of the rhythm for a sinus rhythm is between 60 and 100 beats per minute. That is an impulse that's originating from the SA node that's traveling to the AV node and the Purkinje fibers and doing the contractions that way. Sinus rhythms are always indicative and present when a P wave is present. Like I said, we can make an A. So if we make an A right here, that would be our atrial rhythm. So it's present. So not an atrial rhythm, but it's present with the SA node that's originating from the top part of the atria. So we're going to look and see if it's what the rate is. We're going to count that out on a 6-second strip. It should be between 60 and 100 beats per minute. The next thing that we're going to do after that is we're going to map out the distance between this R wave and that R wave. We're going to measure that, mark that, then we're going to follow it with our paper, see how the other complexes are, and seeing if they're regular. So we're going to identify it that way. So all intervals are typically normal with a normal sinus rhythm, and our rate is between 60 and 100. We have our Q, we have our R, and we have our S, and we have a T wave. So P wave, Q, R, S, T. P wave, Q wave, R, S, T. So I have P waves present at QRS complex within normal limits. My rate, we're going to say that it's within normal limits. Keep in mind this is only a 3-second strip, so this rhythm right here would be 60. So it's within normal limits for sinus rhythm. So my final answer is going to be normal sinus rhythm. When it comes down to talking about a sinus bradycardic rhythm, sinus bradycardic rhythm is going to be a rhythm that has P waves, okay? However, the heart rate is going to be less than 60 beats per minute. Don't be confused that if it's less than 60 beats per minute, that is an AV rhythm, because it's not. We still have P waves present. If the SA node was not firing, we will not have P waves present. So P waves present and indicative absolute sinus rhythm. Typically, a sinus bradycardia can be less than 60. Most people, when you sleep, your heart rate does go not down. We see in deep sleep that the heart rate will go down a lot. If you're working a night shift, which you will see, you'll be able to tell exactly when someone's having a good REM sleep period, or even someone has, they're in a scary dream or anything like that. We will see the heart rate that will spike and then deviations from that. So typically the heart rate is less than 60 beats per minute. It will have P waves present, and this is a normal finding typically in people that are athletes that do a lot of cardiovascular exercise. The one thing that this would not be a good thing to see if it was a bradycardic rhythm, if people have the hypothyroidism, if you have an intracranial hemorrhage, where you have elevated intracranial pressure, you will see that it's pushing on the brainstem, the cerebellum that's controlling the heart rate will herniate and the person will get bradycardic. That's never a good sign. So you want to look at not only are we looking at the EKG tracing, but we're also looking at our patient. So keep in mind as we're looking at EKG rhythms here, it's really important to know that this is only indicating electrical activity. This is not correlating any mechanical capture. How you identify mechanical capture is feeling for a pulse. So at the top of every R wave is where you should be able to feel a pulse. So if I was looking at the monitor and I was feeling for radial pulse, each time I see this QRS complex will be when I should feel for a pulse. So this is an electrical picture of the heart. It's not indicating any whatsoever, when we look at EKGs, any mechanical capture. So as people's heart rates go low, cardiac output also goes low too. Cardiac output is related to heart rate times stroke volume. So if our heart rate does go down, our stroke volume and will also change, and our cardiac output will diminish. If the patient is symptomatic, one thing that we will do for them, we can try some atropine for them. However, it depends on the clinical presentation and what is actually going on. This person was having a heart attack, and I gave something such as atropine to them. I could, in essence, kill them because I could make the heart work more and extend the infarction. A sinus tachycardic rhythm is a rhythm that has a P wave still. However, the rate is above 100 beats per minute. So you see some P waves right here is a P wave. Right here is our P wave. We have P waves for every QRS. So we're going to start with identifying. We have P waves with QRS. Let's just count the rate. I'm just going 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 120 beats per minute right here. So it's definitely over my 100. I'm going to map from each R wave, see the distance, okay? So even though it's a tachycardic rhythm, the distance should remain the same if it's consistent. So we're going to look at whether it's there. We're going to look at our P waves. We're going to look and see that every P wave has a QRS and a T wave. Typically with like I said before, the faster the rhythm is, the QRS complex will get lower. So this is, or smaller. So this is 0.08 right here for our distance. Things that happen with sinus tachycardia, your exercise, your hypotension, as your blood pressure drops, your heart rate goes up to increase. Pain does this. Fever is a common indication for it, as well as hypoglycemia. So when someone has sinus tachycardia, just look at their baseline presentation, see what is normal for them. You can even have hyperthyroidism, where they could have a sinus tachycardia too. So understand the underlying cause of what is going on with these patients. The next thing that we have is premature beats. Premature beats are different. So you will have a sinus atrial rhythm or sinus rhythm that it comes from the SA node, but what happens is there might be a little spot at the top of the heart that gets a little sensitive and says, you know what, I want to have my fun too, and I want to beat. And so what will happen is the SA node will beat, and it says, I'm going to beat my drum too. I'm going to beat my drum. I want to beat my drum. And so what happens is we have what we call a premature complex. And we call it premature because if we were to measure between this R wave, that's going to be the same. But we look, and that is a little premature. It's a little beat shorter than what it should be, which should be, if we mapped it out, it should be right here. So we look at this. Whenever I'm analyzing EKGs, what I like to do is when I see these premature beats, I'll just circle them. So I know I'll circle them that something doesn't look right on the EKG. Then I'll go back and figure out, was this maybe an atrial fibrillation? Is this a PAC, premature beat? What is it? And so I know that this is a normal sinus rhythm because I have a P wave right here. Like I said, you can make your A that is coming out of the atria. I have my QRS complex, which is kind of small to be honest with you, because this rhythm's a little fast. And so there's a CP wave with every QRS complex, and we have these premature beats. What's going to tell me that it's a premature atrial contraction is the fact, like I said earlier, with a P wave, you make an A right here, and this is going to be a premature atrial A contraction. So we have the P waves. Typically, I will tell you, if it was a premature beat, what you're going to see is this P wave looks very much like that P wave, like that way. The P waves are going to be present, but it's not going to be uniform to the rest of the beat because, like I said, it wants to beat its own drum, so it's going to beat a different drum that's going to beat at a different tone that's going to look different when you see it or hear it. So typically PACs are normal. They do occur usually with caffeine ingestion, but I will tell you, anytime you're seeing premature beats, which you should think to yourself is this patient hypoxic, or is there a spot in that atria, the top portion of the heart, that is basically not getting oxygen? So it should be of concern to you. So next we go to atrial fibrillation. Atrial fibrillation is where the heart is having a seizure. So typically you have a sinus SA node impulse that goes to the AV node, that goes to the bundle of the right and left bundle branches and Purkinje fibers. And what you have is, so SA node is one spot beating. Now with atrial fibrillation, this node is trying to beat, but you know what? There's other spots. There's too many people at this party. And so what happens when there's too many people at the party, just a little bit past your comfort zone, you have these abnormal impulses that arise from different parts of the atria, and they just beat and they beat and they beat, and whoever basically can get that beat strong enough that it goes through the AV node and through the Purkinje fibers will get this impulse. And so what you see with atrial fibrillation, we're going to see different P waves because it's from different parts of the atrias, and it's not going to be regular. So this can be a subtle thing, is where someone just basically wakes up and says, oh my gosh, I just feel like I can't catch my breath and feel like my heart's kind of skipping a beat. Well, when it comes to this as atrial fibrillation, it's really important to know and get a baseline in as far as the nursing assessment is, when did this start? When did you start to notice this? Because we can do things if it's an atrial fibrillation. If it's within 24 hours, we can actually convert it. So we can do a cardioversion where we'll put the pads on someone, do a synchronized shock, and try to shock the atrias and kind of slap that. Just the best example I can say is when someone's in atrial fibrillation, it's where you have these kids that are acting out. And I can tell you what, when I was a kid, if I acted out, what my parents would do is they would slap me. And so basically what we're doing, the atrials are acting up, and so what we do is we put some pads on someone. If it's within 24 hours, we'll do a cardioversion, slap them, and restore the normal electrical impulse. If it's more than 24 hours, or someone says, I do not know when this atrial fibrillation started, what we get worried about is, since the atria is basically quivering right here, when it's quivering, we see blood clot formation that can have, because we do not have blood that's flowing normally. So we worry about blood pooling in this area, and it makes us very concerned. So the next thing that we will try to do is, instead of using cardioversion, we're going to try to use medication such as calcium channel blockers to get these impulses firing the way that they should. So most commonly that we use is cardizem, that we use to convert it. Anytime someone has atrial fibrillation, you're going to see, it's going to look like a lot of P waves, okay? The QRS complexes is going to be normal, but you're going to see a lot of P waves. And what these P waves are is related to the pathology and the pathophysiology, where there are different impulses within the heart coming from different areas. So you're going to get different presentations of the P waves that are going to look different in relationship to each other. They're going to have no correlation. So with atrial fibrillation, we're going to see, is this rhythm going to be regular or irregular? And so this is going to be irregular, and we call this irregularly irregular because it's no correlation between the two. And so atrial fibrillation, normal, we have a heart rate 60 to 100. If you may have heard of the term atrial fibrillation, AFib with RVR. What RVR stands for is rapid ventricular response. That is an atrial fibrillation rhythm that is over 100 beats per minute. And so that is AFib with RVR. We do worry about that because when someone has AFib with RVR, this is your most common complaints. How we usually find atrial fibrillation is because someone says, my heart's kind of beating fast, it's skipping a beat, I just don't feel right. And we'll do a 12-lead EKG, we'll see they're in AFib, we're going to put them on a telemetry and look at their heart and this kind of monitor them, and we're going to see that it's over 100 beats per minute. When it's over 100 beats per minute, people can have atrial fibrillation that can go pretty fast, and so as the heart rate increases, our cardiac output is affected by that. And so it's a cascade of things. And so we worry about the blood clots, we worry about stroke, and we worry about cardiac output. So AFib with RVR is really disconcerting to us. Another thing too is you can have atrial fibrillation with SVR, slow ventricular response, and that's typically an AFib rhythm that's less than 60 beats per minute. Most of the time, I can tell you, atrial fibrillation rhythms are between 60 and 100 beats per minute. They're usually irregular. What you're going to see is on the cardiac monitor that it will say 62, and then it will say 82, then it will say 70, it will say 90. The heart rate is going to vary. Also, as you're feeling for a pulse, when someone's heart rate is irregular, then that should tie in that, they might have atrial fibrillation. So normal, SA node for sinus rhythm, everything looks good. Atrial fibrillation, the atrias are having a freaking seizure, and they are just going crazy, and they're trying to fight for their impulse. One thing that I want to talk about too, not to get confused with atrial fibrillation, is something called atrial flutter. Atrial flutter is pretty much the same thing or same pathophysiology. However, it's consistently where the atrias are firing more than the ventricles are. So the heart's having a seizure, this is beating, then stimulates an impulse. This is beating, stimulates an impulse. This is beating, stimulates an impulse. It's like each person's got their firing squad and they're ready to go. With atrial flutter, what happens is you're going to have a foci of the atrias are just beating a lot faster. So atrial flutter, this is the coolest rhythm to me, is I think of flutter, they're waving to you, waving, waving, waving. Then you have an impulse, and so you're going to see the P waves. There are going to be more P waves to QRS complexes with atrial flutter. Typically, it can be regular, and it usually is what we call, so if I were to diagnose this right here, this would be an atrial flutter rhythm with a 1, 2, 3 to 1 conduction, 1, 2, 3, 3 to 1 conduction, 1, 2, 3, 3 to 1 conduction, 1, 2, 3, 3 to 1 conduction. This right here, don't let it throw you off. This is a PAC. This is a PAC too. Premature beat. But this is an atrial flutter is where you see a sawtooth pattern right here. And so this is where the atrias are beating really fast. And then the ventricles are saying, you know what? I can't handle you. We're going to, I got to take a time out for a minute. So you can kind of beat, and then I'm going to contract when I want to contract. So every third impulse that you give me, I'm actually going to do something about it. So there is some variances that you're going to see. So atrial fibrillation, you're going to see a lot of P waves that are different. This is not a good one. P waves are going to be really different. Their rate's going to be irregular. What you have here is this is going to be pretty much regular, and you're going to have usually conduction of 3 to 1, 2 to 1, 4 to 1. Depends on how fast it is. So now, if your brain is overwhelmed, don't worry. Put this on pause. Come back to it. We're going to talk about heart blocks. So if you paused it and you're just returning back, welcome back. If you stuck through it, congratulations. We're going to try to hammer the rest of this through. So first degree heart block, we're going to show some pictures of is a PR interval greater than 0.20. So it's really simple. If our PR interval is greater than 0.20, that is what we call a AV block. And so when we talk about heart blocks, we're talking about the signal between the atrias and the ventricles. There is usually a disconnect. There's a slowness to it, or we kind of get a drop of it, or when we talk about a third degree heart block, there's no association between the two. So first degree heart block is going to be a PR interval between 0.20. That's where your SA node is going to fire, and then it's going to take a little pause for a minute, and then it's going to go to the AV node and then go to the rest of the Purkinje fibers and then make a contraction. So you're going to have a little firing, and then I'll pause, and then it's finally going to get to the AV node. With the second degree type 1, we're going to give some examples, but the secondary type 1 is called a winky Bach. And so it's where the PR interval gets longer, then we have a drop in a QRS complex. A type 2 heart, so a secondary type 2, we call this a Mobitz 2. This is where the PR interval remains the same and everything looks good, and then all of a sudden we just drop a QRS complex. Like, what the heck happened? Like, I don't know. Something happened with that. So we do see that. Third degree heart block is where we have P waves and we have QRS complexes, but they have no association with each other at all. You will maybe see no P waves because they're hidden in the QRS complexes. Another thing that is indicative of these third degree heart blocks is that their QRS complexes are going to be wide. They're going to be wide because the atria are trying to fire, and then there's a disconnect, and then we have the QRS complex that says I need a beat, and so when it beats it's going to be a ventricular rhythm, and so it's usually a wider complex. And so how we treat these, or what we call high degree blocks, is usually with electrical therapy. Atropine will not work on these patients because there's a disassociation between the two. And what happens with atropine or any like epinephrine, what we're going to end up doing is stimulating the atria, and you're going to cause so much trouble that you don't want to do. So not a good thing. So let's talk about a first degree AV block. And these are really cool. When you get into practice, you start measuring them out and you find a first degree AV block for the first time. It's like, wow, so cool. And then you tell the your colleagues, and then you say, hey, that person has a first degree AV block, and they're like, okay, what do you want me to do about it? Because pathologically, we're not going to do too much about it. Like I said, it's where the SA node is firing, and it says, I'm going to fire, and I'm going to take a little break. And then that impulse goes to the QRS complex. So PR interval here, I'm measuring right here, all the way to here. So I have one big box. If I do not have a P wave in that one big box, we have a first degree AV block. So keep in mind, as I'm looking at this first degree AV block, I'm doing my same thing. I'm counting my rate. I'm measuring between this R wave and that R wave to see if the distance is consistent among the two, seeing that I have a P wave for every QRS complex, and then I'm going to go to my PR interval, then I'm going to go to my QRS interval, my QT interval. So in this complex, what we're doing is we're looking at the PR interval, and it's going to be longer than 0.20. So clinically, we really don't do anything about these. This is just something to kind of watch and know that there's a delay that's occurring that we should closely monitor, and just this can turn into other degree blocks. So when it comes down to a first degree type 1, I put here Mobitz 2, but I'm going to change that real quick to winky Bach. I'm going to call this this is a winky Bach. So you have, here's the way I describe this, and it usually typically works. So you have someone that you find super attractive, and you're looking at them and they're walking down that street, And so what you do is you look at them, you make eye contact, you wink at them. Yeah. And so then they get a little bit closer, they go past you, they turn around again, you wink at them. And then they get a little bit further away, they turn around again, you wink at them. And then the next thing you know it, you look back and they've turned the corner. They have gone. That's not good. You've lost them. So what happens with a second degree type 1 is your PR interval is going to get longer, 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 and it just says, you know what, I'm done winking. You're not going to get my wink back. And so next thing you know, we don't have any conduction fully, and so the QRS complex just gets dropped. And then it starts to go back again. It gets longer, 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 and it drops. So your second degree type 1 is your winky Bach. So it's winking, 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 drop. So hopefully that makes more sense with it. Your C PR interval longer, 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 fires, and they're not there, drops. Longer, 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 drops. Now when it comes time to talk about a second degree type 2 heart block, we call it a Mobitz 2. So what we will see within this presentation is the P waves are going to be within normal limits. What we're going to see is just for some darn reason, we don't have any conduction to the QRS. It's like, what? You didn't get my signal for a minute? That's a little weird. So the P waves are firing and then there's no conduction. Like it didn't even go through. It's just like, you hope when you take an ATM machine and it says how much money do you want to take out? It's just like you trying to put in $1 million and it's like it says, okay, it's being processed, but you look and you're like, where's my $1 million coming out of the ATM machine? It doesn't happen. So what we see with our P waves in a second degree heart block, P waves are going to be there. Our QRS complexes are going to decide they're going to work when they want to work. So the impulse may go, may not. So with the second degree type 2 heart block, the thing that we worry about clinically is that we have these missed QRS complexes. So we're like, where is the QRS complex? And keep in mind, with every QRS complex is in essence, your pulse. And so this rhythm right here is only 30 beats per minute. That's not good. And this one right here, 1, 2, 3, 4, 5, 6, 60 beats per minute, that's all right. But, when we start to get besides 60, less than 60, we start worrying about cardiac output being affected. So, like I said, we're going to have P wave, PR intervals are going to be normal. Going to be consistent. We just have a dropped QRS complex. So there's a faulty signal that's not going to the ventricles to do that contraction. So that's not a good thing at all. So with these, we can try giving atropine. I can tell you the American Heart Association guidelines are saying not to do that. What we do with these people is we will put a pacemaker. We will usually put an atrial and a ventricular pacemaker, or we may just put a ventricular pacemaker because the atria is firing, but the ventricle is just not firing the right way. So we usually put a ventricular pacemaker that will help with the conduction. When it comes down to a complete heart block, this is a bad breakup between the atrias and the ventricles. I mean, this is a bad relationship that they end up having. So this can occur in people's younger part of life, or they can have in later part of life where you just, you give up. It's just like if you're married and you thought to yourself, oh God, I don't know how I can do this anymore. This feels like you want to give up. And so when you have a complete heart block, what we're going to see there's P waves that are present, there's Q waves and R waves, QRS complexes. Know how I said earlier, usually The telltale sign of this is your QRS complex is going to be wide. So when it comes to complete heart blocks, usually you will see a wider QRS because this is not a good thing. The atrias are contracting and the ventricles are saying, I'm not getting a signal. I need to fire. So oh man, I gotta do a contraction. So anytime a heart is the main pacemaker where it's trying is always going to be wide. So here you see P waves. I put here P waves and I put where the QRS complex should be. And so you see here where the QRS complexes should be, and they are just not there anymore. You have no association between P waves and QRS complexes. And just keep in mind too, typically we can see at times that P waves are caught up in this QRS complex too. So to discern whether this is a complete heart block versus anything else is we want to do a couple things. We want to look at our rate. Okay, we want to look if it's regular or irregular. We want to look at our PR interval. If our PR interval is some whacked out number, I can tell you this is probably a whacked out rhythm to begin with. So if our P waves are not associated to every QRS complex, then we need to think, okay, we got a second-degree heart block in here maybe, or we definitely got a third-degree heart block. And so third-degree heart blocks, you're going to see no association between P waves and QRS complexes, and you're going to see usually the rate is going to be very low because the ventricles are not beating as much and they're intrinsically going to beat their normal rate. So their normal rate, as we talked about way back in the beginning of this, was between 15 and 40 beats per minute. So you're going to see here 40 beats per minute is this heart rate. This is not good. Someone having a complete heart block, we will do the only therapy is getting electrical therapy, and we will do a pacemaker of the heart, and we may externally pace this person while we get them up to the cath lab. So you will see some other QRS abnormalities besides being a ventricular rhythm. Is you're going to see a right bundle branch block and you're going to see a left bundle branch block. I'm not going to get into much detail other than you recognizing what is right, what is left, okay? So when it comes to a right bundle branch block, here's what I'm going to do. You're sitting in your car, you're driving, okay? You got your nice car, and you're wearing your seatbelt, and you're driving, and you're going to make a right-hand turn. So as you're grabbing that steering wheel, what are you going to do with your turn signal? Are you going to put it upwards, or are you going to put it downwards? So you're driving, going to make a right-hand turn, and you're going to turn your turn signal because you're a good citizen, and you're going to flick your turn signal upwards to signify that you're going right. So you're going to see this R prime R. You're going to have a higher to the right, okay? It's very simple. The only thing that we look at bundle branch blocks, I'm going to tell you, you cannot see a bundle branch block in a one rhythm strip. The best way and the only way to definitively diagnose a bundle branch block is going to be on a 12 lead in lead V1. If you have a 5 lead here, then if you can augment the leads and get that ventricular lead, modified chest lead, then that is good. And then you can do V1. So your EKG is going to go up, okay, to the right. That's going to be a right bundle branch block. Now let's talk about our left bundle branch block. And I like this picture a little bit better too. So right bundle branch block, you have your branches right here, and you just have like it says I don't know, it just burned off for some reason. Physiologically, this can be from a heart attack. Could be a heart attack on the septum right there that affected the right side. So you have it's burnt out from that. It's not conducted this way. So this guy has to take most of the work. So with a left bundle branch block, okay, you're driving. Think to yourself, I'm driving. Definitely not driving in Boston because they drive like crazy. So you're driving and you need to make a left-hand turn. So what way you're going to turn your turn signal? You're going to turn it down. So we're going to look at V1, okay, and we're going to look at the morphology is going to be down, okay? So left bundle branch block is going to be down. If you look at it anatomically, you're going to see a block that's going to occur right here, okay? So bundle branch blocks, significance of it is basically a disconnection there. What we do worry about the presence of bundle branch blocks is in heart attacks. If we have a new block formation and they have chest pain, that is kind of like, uh-oh, they're probably having something going on. So the next thing we're going to talk about is premature ventricular contractions. Anytime you hear premature ventricular contractions, so say with PVC, PVCs are fun to look at on the EKG. They are cool, but I can tell you, we have PACs, that the premature atrial contractions that are originating at the top portion of the heart. Not really bad, okay? Because it's just stimulated, but we still got 2 other strikes before we're out. When we have PVCs or premature ventricular contractions, we get concerned. What we get concerned about is now the ventricles are getting thirsty. They're getting hungry for oxygen, and there's an irritable focus in here. Typically, if we see a lot of PVCs, the first thing that you want to do is look at the person's baseline, see if they're having any hypoxic event. What we do is we monitor these PVCs. PVCs can be indicative of an abnormal focus that is going to be a wide QRS complex, okay? So it's a different beat that's premature, that comes where before it shouldn't have, and it's going to be a wider QRS complex. It's not going to look the same as a normal one, okay? So you're going to see a wider QRS complex. PVCs can be unifocal or they can be multifocal for this presentation. This is very basic that we're just going over, but you can have PVCs in different focuses. This PVC right here looks the same as that one and that one, so what we would do by definition call this unifocal. Going on further, this PVC is occurring every second beat, so we would call this a bigeminy. If you might have heard of it before as that way, trigeminy every third beat. And you may have heard the term as couplets. That is a couplet. There's 2 of them, so you can have 2 PVCs that occur together. Like I said, it's not good. When we see PVCs, one thing you want to think about is, this person is going to go into possibly VTAC, and so your C runs a VTAC, so not really good, but sometimes people may have PVCs. And another thing too, since this is a ventricular contraction, okay, you may usually feel like an added heart rate with it. So if you are feeling for a pulse and it's irregular, the one thing that you want to think about, is this atrial fibrillation? Is this PACs or maybe PVCs? Okay, now moving forward, we're going to talk about ventricular tachycardia. Okay, you have 3 strikes until you're out. You have your SA node, you have your AV node, then you have your Purkinje fibers that go down to the ventricles. And so when that overrides all of the other ones, we go into ventricular tachycardia, or referred to as VTAC. VTAC is not something that's good. You can have a pulse with this, okay? This you can have a pulse with. So we have pulseless ventricular tachycardia, and then we have ventricular tachycardia with a pulse. So pulseless ventricular tachycardia, usually these patients are, well, I can tell you, these patients are unconscious, and this is where we would shock it. We would do electrical therapy if they're pulseless. If they're stable and have a pulse, then we're going to do medication therapy such as amiodarone. Amiodarone is usually a first-line drug that the American Heart Association at this current time does recommend. We're due amiodarone 300 milligrams. We're going to push it over extended period of time of 10 minutes. So we're going to do an amiodarone, see if that converts them. Why do we like to use amiodarone? Amiodarone has a long half-life, so if we're able to convert this, we can take some time to start a drip and do some maintenance versus other drugs such as lidocaine. Lidocaine also has other body effects too. And so amiodarone is more specific to the ventricles. Lidocaine is basically you're numbing the heart. And so we're trying to numb it, put it down. So lidocaine does work. It's just not a first line thing that we would do. So ventricular tachycardia, this is is a life-threatening event, whether it is pulseless or has a pulse. If it has a pulse, we just kind of sit back. We kind of try to be, really concerned with them. But what we want to do is we will try to do medication therapy. If they're unstable and they're pulseless, then we will be doing CPR on this person. And since they are unconscious and their heart is not beating right, so the first thing we're going to do is CPR, CPR, CPR. We're going to prime the pump before we defibrillate it and slap it and say, get back into normal. And so we'll do that, and hopefully that does work and restores the rhythm. Now the other thing is ventricular fibrillation. This is where your ventricles are quivering. So say that we have a heart attack that has extended, burned out our AV node, burned out our SA node, and now it's getting very irritable in the ventricles, and so the ventricles are having a seizure and just quivering. This is where no blood is flowing through the rest of the body, so you're going to see these weird disorganized rhythms. So anytime you see this, double check your patient, make sure they're not brushing their teeth, because they could be brushing their teeth, they could be itching, for example. We've seen, so you see ventricular fibrillation. So uniform is a tachycardia. Ventricular fibrillation is kind of all over the place. We have coarse and we have fine VFib. We're not going to go into details for this, other than fibrillation is where the ventricles are quivering from the focus, and it's not good at all. So the first thing that we do to treat this is that we will do CPR, CPR, CPR. We're going to IV access. We're going to prime the pump before we do any defibrillation. Everyone is pretty much CPR certified, so when you are shocking someone with an AED, when it does say shock advised, so one thing that you're looking for now after going through this lecture is to identify that when the AED is going to shock the person, it is going to be because of a ventricular fibrillation is present. So ventricular fibrillation is when the heart is not getting enough oxygen, is quivering, having a seizure, trying to get any blood flow to the rest of the body, but it's not going to be adequate enough. What does restore that is better medicine, is what we call better medicine with Edison. So better medicine with electricity. So we're going to do shocking using AED, but like I said before that, since the heart is not beating effectively, we want to do CPR, restore the preload to the heart so that when we do shock it, it can pump with a full beat of blood with it. So typically with any dysrhythmias, what we do, we try to improve and identify the underlying problem, whether it's ischemia, heart failure, if it's a valve problem, so forth. We can do drugs that will do the rate, and we do anticoagulation for atrial fibrillation. Pacemakers we put in for high degree second degree blocks, such as second degree type 2 or complete heart blocks. Ablation is something that we do for atrial fibrillation, where we have the different focuses that are trying to beat. So we will go in and burn that area of the heart. Is it successful? Sometimes. It's really hard to identify where these cells are coming from because it's really small. If someone has a history of VTAC or ventricular tachycardia, what we will do is we will put a implanted defibrillator. So they are called AICDs, and so these are put in them if they have VTAC. Another thing too is if someone has congestive heart failure, just to let you know, if we worry about these rhythms such as ventricular tachycardia or ventricular fibrillation, they will go home with what we call a life vest, which is an external defibrillator. Since their heart is so weak, putting in a regular defibrillator implanted is not the best thing. They won't survive. So what we would do is we will put a life vest on them that will, it's basically an external defibrillator and will shock them if they go into those rhythms. So real quickly, we're going to talk about unstable angina. We're going to talk about non-STEMI and STEMI. So stable angina is when we have occlusion that's usually just below 75%, because about 75% people actually have symptoms, so your heart could be occluded. Stable angina is where someone is getting chest pain, usually with exertion, and what they do is they usually sit down, take a break, and then it goes away with rest, or it goes away with the use of nitroglycerin sublingual. And so as we do that, we take nitroglycerin and it goes away, so that's good. When it becomes unstable is where we worry about where they've they've shoveled the snow like they shouldn't have, and what happens is they go and take their nitroglycerin, the pain doesn't go away. So they take another nitroglycerin after 5 minutes, the pain still doesn't go away. Then they take another nitroglycerin and the pain still doesn't go away. Now we go from being a temporary occlusion that's relieved by vasodilation of the nitroglycerin to not, and so we do get concerned with that. So that's unstable. And these people are admitted and they're continued on IV nitroglycerin. Non-STEMI is a non-ST elevated myocardial infarction. This is typically where someone is having a heart attack or may have had a heart attack, but it's not fully present right now. It's not fully there. It's just a partial vessel occlusion. We're going to see things such as CKMB and troponin markers that are going to be elevated in these patients. And then lastly, we're going to have STMI, so ST elevated myocardial infarction. We're going to go through and show you where this is. This is a complete occlusion, which is an emergency. So what we see with the differences, I just talked about these. What we're looking for in any sort of heart attack, we're looking at ST changes. So how the morphology goes is, think to yourself like a floor of a house. You have your basement. So I have a 2-story house with a basement. Okay, 2-story house with a basement. So if I start at the very low level, so ST depression is going to be my injury. Excuse me, not injury, it's going to be my ischemia. Downstairs ischemia, okay, so downward, downstairs lower level is going to be my ischemia. It's going to go down. Then the pathway occurs as I'm coming up to the stairs. I'm going to go to injury, and as I go all the way up to the upstairs, it's going to be infarct. So think of yourself as being in a house that is in the summertime, as you're in a house in summertime and there's no air conditioning, okay? So as you go to the basement, it's going to be colder. So we have some ischemia going on. And now you're going to go to the main floor. It's pretty hot in there. You're going to start to sweat, okay? So you have some injury going on after that. And now you're going to go all the way to the top floor, and it's going to be hot as all can be, and so now you're going to have massive sweating and it's going to be very uncomfortable. So that is kind of the pathophysiology that in the clinical presentations that you're probably going to see with these patients that are having an ST elevated MI. They may have some slight diaphoresis, and it's going to get really progressive as we have the changes that are going on. So criteria for considering whether we have someone having a ST elevated in MI, we have to look at the isoelectric line, and we have to see if there's depression elevation. So we see if there's ischemia, injury, infarct. So obviously ischemia is concerning, not so much of a priority as injury and infarct, because that's presence. We're going to talk about looking at ST elevation in two contiguous leads. So when you have a 12 lead, so you're going to see some couple things of the 12 lead. You're going to see 3 seconds here, 3 seconds here, 3 seconds here, and 3 seconds here. So when you have EKG, it's going to be 3 seconds snapshot, 3 seconds snapshot, 3 seconds snapshot, 3 seconds snapshot. The very bottom of every 12 lead is some of them, it's default to that printer and that 12 lead device manufacturer. You may have what we call lead 2, or it may be defined as that hospital is putting V1 in here because that's the most direct view of your heart. So what you want to say to yourself is when you're looking at this 12 lead, we're looking at ST elevation in 2 or more continuous leads. If I have ST elevation just one lead and not the other one that's associated with it, we cannot qualify by definition that is actually a heart attack. Same thing if you're giving narcotics and you have to waste it, you can't waste it on your own. You have to have 2 people. So same thing with that. So we're going to talk about heart attacks. You want to say to yourself, I see all leads. So we're going to look at leads 2, 3, AVF. These are your inferior leads. So I see V1, V2 septal leads, V1, V2 septal leads, V3, V4, your anterior leads, V3, V4 anterior leads, and V5 and V6 are your lateral leads, and other lateral leads are going to be lead 1 and AVL. I think of L right here is lateral. So here we go. Here's a regular EKG. You want to say to yourself, I see all leads, okay? So we're going to look to ourselves, I see all leads, okay? So let's look at some ischemia going on. First thing that you have with ischemia, think about it in the very basement. That hot day, it's not too warm down there, it's bearable, but kind of a little uncomfortable. You're going to see ST depression. So ischemia goes down and then it goes injury, infarct. So I'm going to show you some different presentations of that. So we're going to see ischemia going on here. And so I'm going to say to myself, I see all leads, okay? I see all leads. So I have to have 2 contiguous leads. So I'm going to look at lead 2, lead 3. That doesn't look the same. Lead 2, AVF. Is there some ST depression? Yeah. And it usually, and I forgot to say, it has to be 2 millimeters, okay, in length. So it's got to be 2 boxes, kind of big. So I see, okay, septal, don't see anything there. Okay, some depression here maybe. Okay, but does this one match that one? No, it's a little progressed here, but I can't call it interior fully. And then I see lateral right here. Boy, this looks very much like that one. So we have ischemia in the lateral portion of the heart. I'm going to confirm this by my other secondary backup lateral leads, which are leads AVL right here and 1. So we have ST depression right here, ST depression, ischemia. Then I have ST depression here, V5, V6, ischemia. So we have ischemia present in the lateral portion of the heart. Now we're going to talk about some injury patterns, okay? So we're still going to say to ourselves, I inferior see all leads, okay? So we're going to look at this portion right here. We're going to look at 2, 3 AVF for our inferior portion. I have ST elevation right here, okay? Not good. So downward ischemia, elevation, injury, high up, infarct, okay? So we have some injury going on right here in our inferior lead, the very bottom portion of the heart. Typically, we call this an RV infarct, the right ventricular infarct. These patients, you want to be very judicious with nitroglycerin, because if we wipe out their preload, we just decrease their heart. Not good at all, okay? So we have injury going on our inferior leads, my C septal and anterior and lateral leads, not too bad. I'm going to do one other thing. I'm going to look at my AVL and my 1, and one thing that I'm going to see here is there is some ischemia going on in my lateral leads. You can see the depression. So what that is telling you clinically, there is a blockage, that is a blood clot for sure, in the inferior portion of the heart, and now it's progressing. The level of blood, the level of hypoxemia is now affecting the lateral portions of the heart. Not good at all. Inferior wall MIs are really, really big. So another thing that we're going to see, so we have ischemia, then we have injury, and now we have infarct. So infarct is going to be progressive of the ST segment, that is going to be so elevated. So we're going to start off I see all leads. So I 2 3 AVF, it has to be in 2 leads. So we have 2 3 AVF. I have 3 more than 2. So that's good. Inferior wall MI for sure. Infarction going on. I'm going to look at V1 and V2. So these two are septal. Here's one thing that's interesting. I'm seeing a ST depression. So there's ischemia going on there, ischemia going on there, ischemia going on there. Okay, so V1, V2, these correspond with each other. So we have infarct in the 2-3 AVF, the inferior leads, and now V1, V2, I have ischemia in the septal portion of the heart. V3 and V4 correspond with each other. V3 is ST depressed, however V4 is not. So I cannot say by clinical definition and rules that they are also having ischemia to the anterior portion of the heart. Lateral portion of the heart, not too bad. However, one thing that I do notice that brings up my attention, I do have some ST elevation here. However, has to be in 2 leads, two confirmations. So I don't see any elevation here. Then here I have some depression, but I don't have any depression. So what's going on here? Inferior wall MI with ischemia to the septal portion of the heart. So that heart attack is going from the very bottom, working its way up the septum of the heart. So we talked about ischemia, injury, infarct, some ST elevations, ST depressions. There is some practice ones that we have here, so we'll just go through it real quick. Tell me what you think. First thing that we're going to do, I see all leads. 2, 3, AVF, what do you see? ST elevation that is profound, really profound. So we have definitely an infarction going on. Inferior portion of the heart. V1, V2, C, septal, don't see anything. Anterior, all, okay. You're going to see an elevated T wave. Okay, don't get this confused with this ST segment, okay. So this is indicative that there's something going on. It could be hyperkalemia that you're going to see this too, but you're not, with a heart attack, you're going to get a slurring. There's not a slurring or what we call a J point to identify. So no slurring present. We just have high peak T waves. So nothing going on in the septal portion, and the T wave's still high, but I'm not seeing an ST segment being fully elevated. So the only thing for this one, oh, keep in mind I forgot this, AVL and 1 AVL. So I have inferior wall MI with lateral ischemia, okay? Inferior wall infarction with lateral ischemia because it's down. Okay, we're going to say to ourselves, I see all leads. 2, 3, AVF, I, inferior. Am I looking for any ST elevation? Don't see any. Don't guess it either. V1, V2, V1, C, septal. Do I see anything here? No. V3, V4, anterior. Do I see anything here? Nope. Now I have V5 and V6. Yes, I have something. These do not look like normal. So we have ischemia, injury going on in the lateral portion of the heart. Two contiguous leads, V5 and V6. So this heart attack, very subtle, but it's kind of big. It's the lateral portion of the heart. You can double check and see if there's other portions of the lateral portions of the heart. And no, so this is a good heart attack to reverse right here. Okay, now we're gonna, this is also a good one. We have 2, 3 AVF. So we're looking for ST elevation, okay? ST changes. I have ST depression here. Profound ST depression. Profound ST depression here too. So that is ischemia going on in the inferior portion. Okay, I, C, septal. I really do not see that big of ST changes here. Anterior, no ST changes here. Lateral, no ST changes here. Now I go and look at my very final thing, my 2 lateral leads, my other ones. Now we have a big problem. This is what we call a fireman's hat, and this is not a good indication. So these two correspond with each other. So final answer is lateral wall infarction or an injury that's going on with inferior wall ischemia. Okay, lateral infarction, 2, 3 in AVF, 3 in AVF, ischemia going on. This is another good one that we're going to do. So I, 2, 3 AVF, I, nothing there, inferior. C, septal, V1 and V2, septal. C, V3, V4, anterior, nothing there. V5, V6, lateral. So we're going to look, ooh, we got some elevation on the ST segment here. So we're going to see this, and we're going to see that it's right here is elevated, so lateral portion, 2 contiguous leads. Now I'm going to go to my other lateral leads right here, 1 in AVL. Now I have also positive indications. This is not a good sign right here. This is not a good sign here too. So what part of the heart's having a heart attack is the entire lateral portion of the heart is having a heart attack right now. Not a good thing. This is another practice one. This is your inferior wall MI right here with ischemia going on in the lateral leads. And I'm going to call this a lateral wall MI yet, but it's just about close. If this was a little bit up, I would say positive for lateral, but this is your inferior wall MI. This is a good EKG too. Just looking at it, see if you're good by now. Where's the heart attack at? This is your septal wall MI, V1, V2. Your septal wall MI. Where's the heart attack at? It's so hard, you can't really see a heart attack. We have some ST depression here, some ischemia going on, inferior leads. I can't call this, even though it looks really bad, I can't really call this a heart attack here because V3 has to be V4. One thing I'm going to point out though is there's something called left ventricular hypertrophy. This is where we have high voltage on our precordial leads right here. So in the lateral portion of the heart. So we will see high voltage where these QRS complexes come all the way down and they will touch the other ones. This is something called left ventricular hypertrophy. We see that in instances of hypertension. Okay. So there's a whole bunch of EKGs that we have different things. I'm just going to show you that. You can pause the video try to practice with it. Same thing with this. You can pause the video, practice with it. Practice makes perfection. So that is about it. I just wanted to point you, I'm going to give a shout out to this awesome website by Skillstat. So I will show you here. I'm going to put a link in the video. This is a EKG and it's continuous, so you can actually go and stop it. And one thing that's really cool is it has a heart rate, and so you can go through and look at the different rhythms. It talks to you more about it, and you can stop it as soon as you put it. So that is basic EKG for nursing students and also paramedic students if you're getting into the field. Again, my name is Justin, in partnership with Professor Lewis Kaplan, RN, MSN with Simmons College of Nursing. Take care.